You're so sweet. Okay, I'll stop babbling now. I know. Okay.
No, that's all right. Oh, and Ann, Jo is not going to be able to join us today. She had an urgent conflict. So you are going to be our first update.
Okay, I will be ready when you tell me.
Okay, thank you. Thank you everyone for joining. We are going to give people a little bit more time because everybody has to we have to let everybody into our room. So thank you so much for joining us today. We're very thrilled that you made the time to join us today. Also, just a reminder, if you have not voted, there's still time. In Colorado, you can actually register and vote on the same day. And so make sure you vote. Okay, we'll give people a few more minutes, like 2 more minutes.
A friend sent me a really neat link. I guess there's a nonprofit organization where you can go in and donate and request pizza for specifically long election lines. And you could do it. I mean, I think Colorado, we should have fairly decent lines since we have the mail-in, but you can donate money, or you can put, if you're standing at an election line and it's super duper long, you can put in requests for some pizza, and they send out some free pizza for people, which I thought was a cool concept.
That's the kind of thing we need more of. I saw the best sign in a neighbor's yard. It looked like a political sign, but it said, I think, "We vote for kindness in 2020. Mm-hmm. Isn't that lovely?
That is nice.
I've seen a few of those. Ann, this is Perry.
Is that Perry?
Yes.
Perry.
Yes, I want to wish you the best of luck in your retirement. It's been a wonderful many, many, many years, going back, I believe, to the 80s when we first hooked up together.
Yep. We hooked up in 89 or 90. You're exactly right, Perry. And we were together on 9/11, and I'll never forget that day.
Neither will I. Neither will I. We were in a meeting when it all came down. We were in the monthly meeting. Yep.
We were in our QA meeting. Yeah.
QA meeting.
Yeah. Wow.
Well, a hug to you and Penny. And
good luck to you, Ann.
This
is Alex Jacobs. We also go back a long way. And I wish you nothing but the best in the future.
Oh, thank you. It means so much from all of you. So now I've taken up enough of your time, Dr. Eber. I'm sorry.
Oh no, we're going to give people a few more minutes because people are joining fast and furiously, which is always great. So we'll give people 1 more minute and then we'll start.
Well, then I have a question, Allison. If I make my kids line up outside my house, will somebody donate pizza?
I think it depends, on if somebody takes pity upon you.
All right.
I don't know. How many kids you got? Does it warrant a long line?
It's 4.
I think I was going to say Galen's would.
I can put the dog behind them.
Oh, yeah. Yeah.
All right. I think we'll get going. So welcome to the CMDA November meeting. We're so glad that you joined us today. We have a full agenda and we have some really special guests. So we're really grateful for people to join us today. So first, we're going to start off with an update from Ann Kokish from CHCA.
Thank you, Dr. Eber. I'll just hit a few highlights, and then if anyone has any more details, I'm happy to try and answer any questions. First and foremost, I'm sure most of you have heard that Margaret Mohan is retiring and Jo is moving into Margaret's position. If we were in person, I would know more. Anyway, I think Jo is a huge loss to us, and I trust she will continue to be a strength for us when she moves up the rank and file as a well-deserved promotion, but we will miss her. Sounds to me like CMS is going to be releasing some guidance related to holiday visitation and residents leaving facilities and how to deal with it. I know this has been a hot topic, and I would just encourage everyone to be talking about it in their community. There's sort of a mixed feeling on whether it's good to go to your residents and families and say, here's the deal. We want to be open and honest. We need to be able to make a plan depending on what your plans are. But there's a worry that that could encourage people to think that they could leave the facility. Anyway, in your QA meetings this week, I would just highly suggest you have a plan for if and when people do decide they're going to leave. Gotten lots of questions on the tents, since tents are available for purchase through the Innovation Grants Board. The most clear guidance that I've gotten is unclear. You need to listen to your local zoning and fire department on whether you can have heaters in there and how to equip those. But if your facilities are considering tents, it might be a good option, but it will be chilly if you can't have heaters. So I would check with your zoning. I'm sure all of you know about I know all of you know about the vaccine distribution program and signing up. Make sure, please, that your buildings have all signed up, and whether they want to designate Walgreens, CVS, or their normal primary pharmacy, it doesn't matter as long as they get their data in there. We are expecting a list from HCA, hopefully by the end of the week or the beginning of next, of facilities that have not signed up or that have not gotten it recorded. And we'll be calling them to remind them. We will try and talk with the administrators. And that's kind of all I have, except the most important thing. I am just so excited to introduce all of you to Erin Thomas. She has started with CHCA. She's Vice President of Quality and Regulatory Affairs, or Director of, or whatever. She will be taking my place, and oh my gosh, it will not be long before you are all just so elated to get to know her. She comes from Madison Partners, where she was the Director of Operations, the Regional Director of Operations for, I think, 6 or 7 years. So she has ops background, she's an RN, so she has the clinical, she's the whole package for all of you, and I will miss you, but I think you will be elated to have Erin joining your ranks. So Erin is on the call today, by the way. Hi, Erin.
Hello, everyone.
Okay, great, thanks.
Hi, Erin,
Thank you,
welcome.
Dr. Eber.
Sure, thank you, Ann, and we want to welcome Erin, and thank you so much for joining us today.
Thank you, Dr. Ebert. I'm happy to be here.
Great. We look forward to working with you. So our next thing is really a privilege. We are here to celebrate and honor Ann Kokish. Ann has been an unrelenting advocate for our Colorado residents, our facilities, and the staff who care for them. The expertise, compassion, and energy that she brings to every single project that she helps create is unparalleled. Her dedication and investment has elevated our community and has made a difference in the care that we provide. She really is the standard. Her help and collaboration for CMDA and our annual meeting has made it a success year after year, and we truly cannot imagine having a CMDA annual meeting without her. Today, we honor the profound impact of Ann Kokish has made on our long-term care community. We have been incredibly blessed to have her in our community. I know that Doug Farmer wished that he could have been here today to also say a few words. He gushes over Ann every time I talk with him. And he wanted to also let us know that Ann has also received the Vista Bowden Award from CHCA, which is the highest award that CHCA gives anyone. And so, Ann, thank you so much. If we were in person right now, we would present you with a plaque. But instead, we delivered it to your home, and I just wanted to read to you what the plaque said. CMDA, the Colorado Society for Post-Acute and Long-Term Care, recognizes Ann Kokish for her years of dedication and service to long-term care. Your compassion and expertise elevate the care in our community. So thank you, Ann.
Oh, Dr. Eber, I'm so totally crying. I'm just blown away. Sorry, now my dog.
Oh no, even your dog is excited.
But I just can't tell you how wonderful you all are.
Well, thank you so much, Ann. I know that if anybody wants to put in the chat some well wishes to Ann, we welcome that. And just to also let you know, we videotape our CMDA meetings, so you can always refer back to it if needed, and you can listen to all the accomplishments of Ann Kokish and how much we will miss her.
No, well, thank you so much. Finally have my barking dog under control. Your flowers this morning were so beautiful, and the plaque, I just became so teary, and now I'm all teary again. So thank you all. I will miss you. You are just the most vibrant, wonderful group. Hugs to all of you. Thank you.
Thank you, Ann. So I hope you'll come to a few meetings in the future, especially when they're in person again. We would love to see you.
Absolutely. Thank you.
So now we're going to move on to our main presentation by Dr. Clay Watson, who is another profound influence and impact in our long-term care community. We're so lucky to have him here today. And he's going to talk about, I hope I'm going to say this correctly, 1 little, 2 little, 3 little pathogens, how to differentiate COVID-19 from flu and RSV. So thank you, Clay, for being here. We're thrilled that you're here, and I'm going to turn it over to you.
All right. Can you hear me okay?
Yep, you're fine. You're great.
Okay, and everybody can see my slides. Is that true?
I can see them.
Yes.
Okay.
We see it. Yes, we see
Yes.
it.
Wonderful. Thank you. And I was looking this up and going through some of the background data. So I'm going to talk a little bit, obviously, about differentiation and maybe a few other things. And I slipped RSV out of there, but more the common cold. RSV will come later. And in the era of COVID, things change hour by hour. So we have almost infinite time before RSV is a huge problem for us anyway. But flu and cold season are nearly upon us. If you've been at my house, cold season is very well upon us. So with that, let's get going. So what is it? Is it cold season? Is it flu season? Should we argue about it? Probably not. All 3 of these things are going to be circulating in all the homes. And so we need to be prepared. So we'll do a quick viral comparison, a quick disease syndrome comparison. I haven't seen a ton, I've seen a ton of questions about this, but I haven't seen a ton of data about post-acute COVID or long COVID. So I'll briefly touch on that, sum up some data from a paper about flu and COVID co-infections. And if there's time, we can briefly talk about COVID vaccines, and if not, no big deal. So I know Dr. Gahm loves the COVID-19 background, so I thought I would give equal time to the beauty and majesty of the hemagglutinin and neuraminidase proteins on the influenza surface. So there they are, side by side. So very briefly, you know, these are similar viruses in many ways. The properties of the flu virus, our vaccines cover 4 strains. The RNA is segmented. That's one reason it's such a headache to make a vaccine, right? We can shuffle out different segments, or we can have mutation in certain different segments. Antigenic shift versus antigenic drift, if you can all remember hearing that in medical school. So flu viruses are a pain with all those segments. And they are enveloped viruses, whereas SARS, you know, coronaviruses are normal cold viruses. This particular one is quite a bit more nasty, but it's one strain. It is, again, RNA, but it's one solid genome. It's not segmented. And so I'm hopeful that our vaccines will be more effective or more durable against the virus than our annual flu vaccines. But that's no guarantee by any stretch of the imagination. Both of these are RNA viruses, so they are susceptible to mutation as they don't use all of the cell's proofreading capabilities. when we look at the replication number, the R naught, if you will, flu doesn't seem to be quite as infectious as COVID-19, about 1 person versus 2 to 2.5. I think this is an important distinction, the incubation time, 1 to 4 days on flu. If you remember nothing else, remember flu is fast, right? You get exposed, the next day you feel terrible, it jumps on you and you feel it accelerate throughout the day. Whereas COVID is 1 to 14 days, you know, maybe more in the 5 to 6 day range would be the most common. And it's, for many of us, it comes on slowly over days. There are some people who rapidly progress to shortness of breath, but in general, flu is faster than COVID. Obviously, we have a much higher hospitalization rate in COVID and fatality. The numbers for flu are obviously post-vaccination, advent of the vaccine, that is. So I thought this was a great chart from Yale New Haven Health, comparing allergies, cold, flu, and coronavirus. And it is probably reasonable to spend some time here. We'll leave allergies out. I don't think it's hard to differentiate that. But cold and flu are pretty similar, right? Body aches and cough. For me, when I think of flu, I think of high fevers, greater than 101, 101.5, a lot of fatigue, and headache. And I think that really differentiates it from the cold. So, you know, cold, you have that sort of upper respiratory stuffy head feeling, whereas flu, total body, I just want to go lay in bed. And then COVID, you know, COVID more prominent with the cough, can have fatigue, lower fevers, particularly for our population, 99 to 100.4, not big fevers. And then sort of the big hallmark, the shift in disease severity is that difficulty breathing and shortness of breath, which we really don't see very much with flu. So we could probably spend an hour on this, but I'm happy to send these slides out and you can really kind of spend some time thinking about that.
Dr. Watson, there was a question in the chat box regarding COVID-19 compared to influenza. Is it true that COVID-19 has better proofreading and hence less mistakes and mutations?
Is it true that COVID-19 has better proof? You mean proofreading of the genome itself?
Yes, that question was for
during viral replication?
Yes.
That is a good question, and I would have to think about that. Both are RNA viruses. One is negative, one is positive. They both tend to mutate fairly rapidly compared to, say, a DNA virus, but I don't know about a differential rate there. I'm sorry.
I read that someplace, but I didn't know if it was accurate. Thank you.
Yeah. Okay. So let's talk about post-acute COVID. That is not a facility where COVID goes to recover after a large surgery or a knee replacement. It is actually defined as the syndrome that lingers on beyond week 3. So I thought this was a great article out of the British Medical Journal that kind of summarized evidence to date in August, but I haven't seen a ton of evidence come up since then. So post-acute COVID, about 10% of people, now this is everyone, not just in our population, our age group, but the whole gamut, about 10% experience prolonged illness. Many recover. Their definition was between 3 weeks and as long as 12 weeks. And even mild COVID can have some of these symptoms of cough, low-grade fever, fatigue, and it's sort of relapsing remitting. And we've had that, I've seen it even amongst some of our providers who are trying to get back to work. And they're feeling better, they want to go, and then lo and behold, here comes another temperature of 99.9 and their cough is back. So I've seen it affect people. I'm sure many of you have as well. Other reported symptoms include all of these. So shortness of breath, muscle pain, GI issues, metabolic issues, thromboembolic conditions, and I know we've all heard of the skin rashes, which can be anything, vesicular, maculopapular, or even the chilblain type lesions. So a wide variety of issues. For our population, I think these neurocognitive difficulties may be prominent. Of the people who have post-acute COVID, up to 20% can be cardiac or pulmonary. So things like myocarditis, pericarditis, myocardial infarction, PEs, and dysrhythmias. People could recover from disease and then develop these syndromes or develop them as part of their disease. So something to be mindful for in that sort of post-acute infectious time period. If somebody starts developing chest pain and lower extremity swelling, you may want to check out their heart. There are other chest pain syndromes, which can be just musculoskeletal, and then also a breathlessness, which can be described as a burning sensation on inhalation. And so be aware of that in yourself if you have COVID, but also in the patients. People with breathlessness do respond to pulmonary rehab or deep breathing exercises. So it's worthwhile. I think we're all aware of the thromboembolic complications of hospitalized patients. Most hospitals are anticoagulating patients at least prophylactically for 10 to 30 days post-discharge among those that are high risk. And then the neurologic disease, just sort of headaches and brain fog. I some days could claim that I have brain fog unrelated, but it's more of a persistent brain fog and is also associated with the breathlessness. Fortunately for us, the other complications like stroke, seizure, and encephalitis have been rare. Any questions about post-acute COVID?
Dr. Watson, this is Singh Pallet. If we think we have patients who have these syndromes, like who are the experts in this post-acute COVID? Do we have post-acute COVID clinics in the Denver metro area, or do you just kind of go to the cardiologist and the pulmonologist as you see fit?
Yeah, it's an awesome question. And I would say nobody is I think I'm looking at all the post-acute COVID experts, right? We have high rates of infection. We have high rates of serious infection, and we have seen, if you will, the dwindle amongst our patients where they're not eating, or they have nausea, or they feel depressed. And so I think in terms of recognition, we've got the most experience. In terms of treatment, I think it's going to be along the lines, if you're getting into an area that you're uncomfortable, obvious cardio problems, you're going to send them to a cardiologist. Neurologic problems, those could be emergent. But if they're not, we can wait them out if it's a mild headache, but we may need further assessment. But there's not one group that really specializes in this. I think it's going to fall on us. And then when we need help, we're going to have to call for it from the specialist.
Thank you. And Dr. Bolshon left a question in the chat box. Who is at high risk for COVID thrombosis? And do you count on CHADS VASC scores?
Yeah, I would say traditional risk factors. And if somebody said that to me, I'd say, well, that's everyone, because they're going to go to a nursing home where people are isolated and they're short on staff and and that's a high risk person, right? Or multiple comorbidities. But yes, in general, I would say the people who were more sick, the people who had elevated D-dimers in the hospital, and then people who have high normal thrombotic risk factors would be the ones that are considered high risk.
Thank you.
Since we live in Colorado, this was an interesting statement about recovery for a sports person. Again, this was British. So I said, I was thinking that's the elite athlete all the way down to the weekend warrior. But you can see how they spell out to cautiously recover and to limit your high intensity or your interval training. And I'm thinking, clearly they don't live in Colorado, because if they had to bike up a hill or up a mountain, they would probably lump that in. My heart rate goes way above 60% of my maximum heart rate. So I would probably be doing nothing to recover from COVID. But there is a whole statement in this paper, which is referenced at the bottom. So I would encourage you to take a look at that because it does have some recommendations about pulmonary and cardiac assessment before resuming full activity.
There's a question.
Yeah, go ahead.
Sorry, thank you. Dr. Ebert has a question about, what if a patient has chosen not to go to the hospital? What criteria would you use to consider anticoagulation in a COVID positive patient?
Yeah, I think one, it would be goals of care always come first. Second, it would be severity of disease. Did they get to the point of shortness of breath where they required oxygen? I would, in someone who has more severe disease, I would check some of the labs associated with it, increased inflammation and thrombotic activity. So sed rate, CRP, D-dimer, those types of things. That's how I would assess. And there are, you can look up protocols from most of the hospital systems, and they'll have lab values graded out in terms of risk. So that's probably what I would use. I wouldn't do blanket anticoagulation because the risk of bleeding, right? So all this has to be balanced against the risk as well. But briefly, that's how I would do it. Or that's how I do it. So maybe if COVID and flu started co-infecting people, if the bad guys got together, what would happen? I think that's a question on everybody's mind, and maybe on the front of everybody's mind now as we head into flu season. And so there was a nice paper from Public Health of England that addressed this issue. And I think it's got some important points for us. So I will highlight those. So it's interaction between SARS-CoV and influenza. This has not yet been peer reviewed, but it was early released on medRx, and that was September 23rd, I believe. So about 19,000 people who were tested for both flu and SARS from January to April 2020. So I would assume that none of this testing was screening. It was all in symptomatic patients. And likely many of them were hospitalized. So this was distribution. Along the x-axis there you can see, so this is week 1, not January 2020, week 1, week 2, week 3, week 4. And so you can see all of these people who were co-tested, so only people who were co-tested. So they started testing in the 4th week of January, all the way out to the 17th week out here, which is towards the end of April. So the green is influenza, right? Influenza alone. The dark blue is COVID and influenza negative. And the red are the co-infections. While I'm not happy to see co-infections, I'm happy to see a very tiny column. I think we should all be happy about that. And so what does that really tell us? that you can have a lot of COVID and a lot of flu, look here in week 11, and you really don't have that much co-infection. And I apologize for the blurriness of this, but if you look at just this column here where influenza is positive, so these people all tested for influenza, you can see that, you know, in week 11, 330 were negative and 12 were COVID positive. So here's your co-infection. So it's quite a small percentage, right? 3.5%. The percentage goes up, but I think that's due to the overall lowering numbers of cases that were co-infected. And so what can we tell from that? Well, there's this thought of competitive inhibition, right? So here's our respiratory epithelium surrounding the watering hole here, all the prey animals. And these three guys don't hunt together. They don't work together. They don't even like each other. In fact, they fight amongst each other. So if flu is active down here, it's likely going to inhibit the other two. One of the components of that is interferon, right? That's antiviral. It inhibits entry into the cell. So that's a good thing for us, that we're not seeing collaboration between the viruses, because we would hate to see a bunch of hyenas herding all these animals towards the lion. This was interesting, I think, out of the same paper. So again, co-infection by age, and we know the punchline, right? The older you are, the higher the risk of co-infection. And look at that mortality risk. 66%, 2/3 of people over 80 died. 57 over 70 died, 57%. And this is against sort of the traditional mortality rate of 15 to 20%, which was true back in the spring. So when they do get co-infected, it's devastating. So our respiratory epithelium, as it ages, it becomes much more fragile and susceptible to co-infection. And then finally, if we just look here in this column, the odds of death, just COVID and flu negative, the odds ratio is 2.6, whereas with the co-infection, 5.92. So the odds of dying when you're co-infected are higher than they are if you have only COVID, and certainly if you have only flu. Oh, there was another, there we go. That slide was next. So we don't see this very often, but when we do, it's very bad for us, right? Co-infection, not healthy, to complete the whole metaphor there. So hopefully we will not see much of that. So the summary, the risk of testing positive for COVID was 58% lower if you had flu. And the mortality rate was much higher, 43%, and 80% of those were over the age of 70. So our population, right? And then we covered the rest of that. So what can we do? I think consistent application of infection control, that's the hardest thing to be consistent. But a single mistake can carry the disease around the entire population. We can make sure that our patients, providers, and staff have the flu shot, because that will decrease illnesses and decrease the spread of the flu virus. I think rapid clinical evaluation by one of us is extremely important, and we can place the person on isolation. I hope everyone on the call would echo when I say, please don't close facilities to providers. CMS addressed this in July with their guidelines stating that providers are necessary, and it's reasonable to have them test. It's reasonable to exclude them when they are on isolation due to an exposure, a high-risk exposure, but it's not reasonable to blanket say no providers can come in. I think that hurts our patients. And once the virus is in there, I don't know that the providers are the highest risk of people to bring it in. So please don't close buildings to medical experts. That's probably not the best solution. I think isolating symptomatic patients and testing for both flu and COVID are going to be critical. And then I think all buildings should have their influenza treatment and influenza prophylaxis protocol at the ready, and everyone should know when to trigger it so that we can stop the spread as soon as we need to. COVID vaccines are coming. None of the vaccines have full FDA authorization in the US yet, but several have completed their trials in terms of having all of the patients enrolled. One is 30,000, that's the Moderna. One of the other ones has 43,000. And they are monitoring this population to see if it's protective against infection. So as soon as that data is turned in, I'm sure it will be fast-tracked. And we should start to see vaccine deliveries in the first quarter of 2021. So with that, I'll stop and answer any more questions, if there are any.
Yes, thank you. There's one in the chat box regarding the vaccine. What about the timing of giving a flu vaccine with someone who has COVID?
Yeah, that's a good question. So I haven't seen a ton of data on that. I guess what I would say is someone had a milder case, meaning no shortness of breath. They didn't get steroids. They didn't go to the hospital. I would use the same guidelines. I wouldn't give it to somebody who's febrile or actively sick. But once they're outside that window, I would feel comfortable giving them the vaccine. Now, if they were someone who was more sick, maybe they were lymphopenic, maybe they have this long COVID syndrome, I would wait as long as I could safely, but we're rapidly running out of runway. And it's better to have the vaccine than to wait for the perfect time to give it, right? I think if they haven't already had it, as long as they're not febrile and actively ill, I would go ahead and give it.
Thank you. Dr. Thompson's asking, how comfortable will you be giving a fast-tracked vaccine? Is it safe and effective?
That is an awesome question. And it's a deeper discussion. I guess I would probably be uncomfortable at a baseline. I would be more comfortable with the vaccines that are proven viral vectors that we've used in the past, or proven methods that we've used in the past. mRNA vaccines have never been used in humans on a large scale. So I'd probably be a little less comfortable with that Moderna vaccine. But if I was very high risk and I was facing potential death from that disease, I would definitely consider taking it myself. But your question is a good one. How can we take a disease or a development process that typically takes 5 years and cram it into 9 months and assume that it's safe? I think that we've covered a lot of our bases, but we can't know everything. So it's a great question. It's probably one that all of us are asking ourselves.
Thank you so much, Dr. Watson. I just want to see if there's anyone else who has any other questions. There is a lot of things to ask about. I think we have one more question, and I'll let Singh take that to pose to you.
Sure, thank you. Looks like it's from Dr. Williams. Recommendations for therapeutics with patients who decline vaccination.
recommendations for COVID therapeutics for those that decline COVID vaccination, or are we talking about influenza?
Is that you, BJ? If you want to clarify the question, feel free to. Just COVID, he said.
Yeah, it's me. I'm just
Hi.
yeah, sorry, I'm jumping in. I
Please.
know I came in a little late, so I didn't know if there was any discussion about the therapeutics with like with people who've already declined and they're on our radar and we have suspicion that they might have it and they get it, kind of thing. Or where are the therapeutics is really what I'm getting at.
Yeah, so we didn't cover much in the way of therapeutics for COVID. Obviously, we are aware of many of the treatments which are available only in hospitals, things like remdesivir, the plasma, things like that. I think the things that we can do in our population in the nursing home would be steroids, the higher dose steroids. I don't think that the recommendation has changed. We would like to see them on an increased oxygen requirement, or shortness of breath, or evidence of infiltrate on the chest x-ray, things like that. And then I think some of the other therapeutics that are hinted at, things like anticoagulation, would be made on individual basis, depending on what those, depending on risk factors.
Gotcha. Thank you.
Sure.
Yeah, we're kind of limited in what we're able to do. So yeah.
Dr. Watson, what are your thoughts about possible COVID reinfections after 5 or 6 months of the initial COVID infection?
Well, I think we've seen it. So it happens. And I guess the question then becomes, will this be on a broad scale? Or will the other major question that is born out of that is, are you at equal risk the second time you get infected? Usually with respiratory infections, you can get a second infection, like with a coronavirus that's not COVID, but it's not that severe. So yes, they do happen. We have evidence of that. Is it everybody? I haven't seen that. It seems to be a smaller proportion of people who do get reinfected, but there is evidence of some waning immunity based on antibodies. However, I think that's a big area of research where does the cell-mediated immune response persist longer? And probably it does, and we'll just have to see what comes of it. I think there's a lot more evidence to come as we see the cases climbing everywhere in the nation, pretty much.
Also, I'm sorry to ask one more question. So how do you extrapolate that information to the effectiveness or the waning effectiveness of a possible vaccine? Do you have what are your thoughts about that?
Yeah, it's a great question. I think a lot of these vaccines are 2 doses, probably for that reason, right? We're trying to get a super immune response. We need a response greater than the disease itself generates. And that's not easy to do. So some have adjuvants, some are multiple doses. Is it possible? It's possible, but we already have that with flu, right? Flu immunity wanes as well. So we may end up with what will be seasonal vaccinations for 2 respiratory diseases.
And I have a question about genome sequencing. I'm not sure if that's the right term, but in Colorado, is there the ability to do any genome sequencing? Is there any role for that if we're reevaluating someone who might have a reinfection?
Viral genome sequencing?
Yes.
To see if there's a mutation in the virus. I mean, does that capability exist? Absolutely. University of Colorado Health Science System has it. In Boulder, in Fort Collins at CSU, they all have that capability. I don't know if it's being done on as a matter of, I don't think it's being done clinically. And I'm not aware, I just don't know about the research that they're doing. I'm sure that some universities are sequencing to track mutations. We have seen data about that, but I'm not sure about what's going on in our state.
I'm seeing something in the chat also from Renee Marquis that the state lab is doing genome sequencing for repeat positives after 90 days.
Nice.
I also have some information. There was a question about veterans and their access to specialists via telehealth, and information from Carrie Levy that we can have our pulmonary critical care docs see any veteran via telehealth. They are becoming experts in this, and we've done nearly 800 nursing home teleconsults to local and rural nursing homes for all sorts of specialties. So that does exist for veterans, and certainly that's a gift. Thanks, Carrie.
And I know some of the private groups around town also have telehealth capability. So they could do that as well. My daughter's asthma doctor does telehealth with her, and I know some of the GI groups have telehealth. So I think if you need a specialty consult, particularly in a nursing home patient, both to protect them from exposure going out, but also to get a timely evaluation, and especially since you're already an expert healthcare provider, sort of having a telehealth consultation with you present would be ideal, and probably would get faster results than if you tried to schedule an in-person appointment.
Thank you. Dr. Watson, if you could, what has been in the past month, you think, your pearls that you could share with us about treating patients with COVID-19 or with a respiratory illness? What would be your best take-home messages for us today?
Whoa. I mean, there's a lot there. So I guess one thing I think is going to be extremely important in the coming months is discipline. Discipline with PPE, discipline with testing, and discipline with treatment in terms of, let's not just go hog wild because there's a new piece of evidence on this one treatment, or let's not start everybody on influenza prophylaxis because somebody has a cough. Let's stick to what our protocol is and maintain discipline. And that discipline will keep our outbreaks in our homes to fewer patients, and make us better diagnosticians, I guess. It's the hardest thing to do. I know when I'm working, it is, not that I don't work, but when I'm working in a clinical capacity, it's the hardest thing for me to do because I want to do something. And I have to resist that temptation, taking care of these patients. Because they're scared. They're panicked that they have COVID, or they're panicked that they have flu and they don't want to go to the hospital and it starts to spiral. And you just have to be that calm rock for them to lean on and maintain your discipline.
Thank you so much. There is a article from JAMA called Sensible Medicine, which reiterates what you've just said. It was included in the CMDA agenda sent out on Sunday. So I encourage everybody to look at that JAMA article, and it will say exactly what Dr. Watson just said. So thank you.
We didn't even plan that.
Another question in the chat box too.
Go ahead.
Andrea Stand is asking, my understanding was that there have only been a few confirmed reinfections in the US. Is that correct?
I don't know that I know the sum total of all of it, but there was evidence early, even from the naval ship that had so many infections and some of the cruise ship patients. But then there have definitely been many documented infections through nursing homes, right, where we're doing consistent screening. So person got sick, person went to the hospital, had a positive test, came back, had 4 or 5 negative tests through screening, and then another positive test. So extreme with some symptoms. So extremely clear evidence, but I don't know how many people that is. But what I do know is it's not everybody who was previously infected. So again, it's some percentage of people can get reinfected, but I'm not sure where that percentage lies.
I don't know if that question kind of came after the previous one about the genome sequencing. And if Dr. Marquardt's still on the phone, is there some sort of protocol through the state lab on reevaluating or evaluating these people with repeat positives? And is there some sort of protocol for requesting genome sequencing?
Yeah, hi, am I off mute?
Thank you.
Yes, you are.
Yeah, okay. Yeah, they are looking at that at the state lab. It doesn't always yield results, but if they do have the prior test sample there and then somebody tests positive again after 90 days, which has happened quite a few times, they are looking at that. I haven't heard anything conclusive so far about if they've found clear evidence of reinfection. A lot of times all that investigation ends in no clear answer, but they're definitely looking at that for that reason.
And, I'll just throw in that we've been through the research stuff, looking at it through CSU as well. And we've seen some virus shed, so positives months and months and months after the initial one, and they are doing the gene sequencing and have yet to see a reinfection, so a new strain. But that's not huge numbers.
Thank you. Thank you so much, Dr. Watson, for that incredible presentation. I'm actually getting a bunch of compliments on your presentation right now. So lots of people are very grateful for your sharing of your knowledge. Thank you.
My pleasure. Thanks for having me.
Sure. Now we'd like to go to a flu update, which is super important these days, and Dr. Greg Gahm.
Actually, this will be really easy. The part of Clay's talk where he talked about the viral interferon, I think really is working. We have less flu across the country and in Colorado right now, first week of November, than we've had for 2 decades at this time. Maybe it'll be a mild season because of that, but there's really just no flu out there. I think it's worth, obviously, I want to get everybody vaccinated. For seniors, again, my personal opinion, wait, be patient, give it in late November, early December, so that the immunosenescence doesn't really play a part in them getting flu late in the season. But make sure you give it. The other thing is, and I don't understand this one, but it has been really hard to get the high dose in the adjuvant vaccines. Some facilities have it and most don't. I would say for right now, don't be nervous about that. Again, because I'm telling you, my preference is to wait, even if you have it, wait until the end of the month or first part of December to give it, unless we, out of nowhere, see a major spike in flu A, in which case we can give it pretty quickly. And just hope that they get the vaccine through the distribution channels. If they don't, I'll tell you that it is absolutely acceptable to give seniors 4 doses of the standard quadrivalent vaccine. And it will be, other than they'll get an extra 1.5 cc's of saline, it will be absolutely equivalent to giving them the high dose vaccine. I don't think you'd want to use that strategy because you'd run out of that pretty quickly, and it would sound funny and you'd only get reimbursed for the first one. But it certainly is a possibility. So really the news on flu is good right now.
Thank you so much. Does anybody have any other questions for Dr. Watson, Dr. Gahm, anyone else? The floor is open if you have any questions or concerns.
I'll throw one out there. We are just in the past week, it's unfortunately following exactly the timeline we thought would happen. Schools start, people get tired of COVID, it spreads in the community, then it spreads a lot, and then it gets into nursing homes. And we've seen more cases among residents in nursing homes in the past week across the state than we have in the previous 2 months, probably. And it's coming in, the residents aren't bringing it in. It is time to really encourage your staff not to have COVID fatigue, really to wear masks out in public. Don't congregate, just keep it up, and vaccine is around the corner.
And just to dovetail on Dr. Gahm's comments, which are so welcome, I think one strategy to encourage staff to stay the course is to make it a habit. You know, when we get into our car, we put on our seatbelt. That's what we do. So when we walk into work, we put on our mask, we leave it there until we go outside, and we can take out our masks then, and we know how to use PPE, and that's our system. And so encouraging staff to make it a habit, that is just the new normal, I think can help us have more dependable results in using our PPE and making safe decisions. So just one idea. Okay, so does anybody else have any other questions or concerns? I thank you all for joining us today for the CMDA meeting, and I look forward to seeing you in December. Please get your flu shot, vote, be safe. Don't go to a lot of gatherings. Try not to go to any, and be kind to one another. Thank you. Bye-bye.
Thank you.
Hi there, guys.
Hi.
Oh,
Thank
hi.
you for leading the meeting. So much great information.
Oh my gosh, Dr. Watson did an incredible, incredible job.
Yeah, that was really great. I found myself taking a bunch of pictures of the slides, and then I was like, oh yeah, he's going to send those.
Allison,
they were
can
good
you
slides.
can you encourage Clay to send it to me, and then I'll send it out sometime this week to everyone. They were so incredible.
Yeah, I will ask him for that. Yeah.
Great.
Ooh, good meeting. Good meeting. Well, thanks, guys. Stay safe today. Stay sane.
Yep. Take care. Thank you,
Bye.
everyone. Bye.
Bye.